So our first part of today's lecture will be about post-operative instructions. So by post-operative instructions, we mean the instructions that which we give our patients after extraction. Uh, we are going to specify more about dental extractions because your course is about dental extractions and what are the instructions which the patient should follow after extraction. So this is going to be the primary learning outcome in this lecture. So when we do an extraction to a patient, we'll always have to tell the patient what to expect after oral surgery, like what to expect after the tooth has been removed. So the patient should know that minor bleeding and oozing is normal. It usually happens up to 1 day or 24 hours. And pain and discomfort will slowly improve. So although pain will be there in a severe form in the first 1 day, then slowly it improves over 3 to 5 days. And if it is a small surgery, especially if it's a transalveolar extraction where there is cutting of bone or sectioning of roots done, the patient should also anticipate swelling. And usually swelling is more in the first 1 or 2 days after the surgical procedure, but slowly it improves. And by 1 week after surgery, the swelling will completely disappear. Similarly, the patient should also understand that any procedure that is done in the molar teeth, the patient might have stiffness in opening the mouth. So this is because of the close proximity of the muscles of mastication. So when we do an extraction, after extraction, there is inflammation, and this inflammation can progress up to the muscles of mastication. And because of that, the patient might have difficulty in opening the mouth. Similarly, any extraction procedure that requires inferior alveolar nerve block, this can also cause stiffness or trismus. This is what we call it as difficulty in mouth opening. We call it as trismus. So the patient can have trismus after an inferior alveolar nerve block injection, especially when we accidentally prick the medial pterygoid muscle, which is again a muscle of mastication. So these are things which patients should normally anticipate or expect after a dental extraction procedure. So based on this, we design our post-operative instructions. So the post-operative instructions can be classified as general instructions. Then there are instructions regarding physical activity. Then there will be instructions regarding the diet and medication which the patient should follow. So it is important that the instructions are given clearly and they are communicated very well to the patient and made sure that the patient has understood the instructions. Whenever possible, if you have a patient who is a child or the patient has some learning disabilities, they are not able to understand what you explain, then you should tell to the nearest of the caregiver, which may be a parent or an accompanying person. So the instructions which are generally told are the patient has to bite on a piece of gauze as they leave the clinic, and they have to keep biting on this gauze which is placed in the extraction socket for at least 30 minutes. The idea behind that is to allow the blood to stop and also a clot to form in that area. So if you take the case of bleeding time and clotting time, nothing is more than a minute. Okay, so normal bleeding time is few seconds and the clotting time is up to a minute. So then why are we asking the patient to bite on the gauze for 30 minutes? We don't only want to stop the bleeding, but also want to have a clot formed in that area. And that clot should stick onto the socket walls. So this is the primary idea behind telling the patient to bite on a gauze for 30 minutes. So what should they do after 30 minutes? After 30 minutes, the patient can remove the gauze, and this gauze should be removed with the hand and not spit out. So if you spit out, you will create a negative pressure. So advise the patient not to spit out. Rather, the patient should actually remove the gauze with their hand and examine the site in a mirror. Okay, they can do a self-examination to see if the area has stopped bleeding or there is bleeding in that area. So the patient has to be informed that little blood with saliva, mixed with saliva, is normal. This is not a lot of blood. They should look into the socket to see fresh bleeding. There is blood coming out continuously. So if that is the case, then the patient is advised to bite on another piece of gauze. So when you discharge the patient, we always give them few pieces of sterile gauze extra so that when they go home, when they remove the gauze that you placed, the clinician placed, when they remove it after 30 minutes, and if they see fresh blood coming from that area, they will put a fresh piece of gauze and bite on it. Okay. And this can be repeated every 30 minutes up to around 2 to 3 hours. If there is persistent bleeding beyond 3 hours, then the patient should visit the emergency or should seek the doctor, okay, to see if there is any problem or if there is some suturing or some hemostatic agent has to be placed. But again, you have to reiterate to the patient that look for fresh blood. Okay, if you see blood mixed with saliva, then probably it is the blood color from the clot which is being released, and that mixes with the saliva and looks like blood. Okay, so that is not fresh bleeding. So this has to be told to the patient. In addition, we also give certain other general instructions like not to smoke if your patient is a smoker. So smoking here includes cigarettes, electronic cigarettes, vaping, shisha, every form of smoking. Okay, so they should not do it for at least 24 hours. The ideal time limit is at least for 3 days after surgery. The patient should not do smoking. But you see, patients have a habit of smoking and suddenly withdrawing it may not be possible. So in such cases, tell the patient to not do it at least for the first 24 hours. Two reasons why the patient should not smoke. Number one is the heat of the smoke can break down the clot. So we don't want anything hot going into the extraction socket within the first 24 hours. This is number one. The second thing is all the chemicals that are present in the smoke, whether it is an electronic cigarette or a vape or shisha or the regular cigarette, all of this has certain chemicals which can interact with the inflammatory process and can result in clot breakdown, delayed wound healing, and other problems. So for this reason, the patient should be asked not to smoke. Second thing, spitting. Don't spit. The idea why we tell patient not to spit is spitting causes a negative pressure inside the mouth. A negative pressure is like a vacuum. Okay. So when there is a vacuum or negative pressure inside the mouth, this can suck the clot out of the socket. The extraction socket has a clot stuck to it. So when you make a negative pressure, the clot can be sucked out. And when clot is lost, that is the primary cause for dry socket. That is the primary cause for delayed wound healing. And that is also a contributing cause for wound infection, extraction wound infection. So never ask the patient to spit. Okay. If they want to spit, they have to do it very gently without causing suction inside the mouth. They should also not use a straw if they are drinking something, okay, after extraction the first 24 hours. Usually we tell the patients to take soft diet or something liquid. So it is better for them to drink it directly from a cup rather than using a straw. The reason again is drinking with a straw causes a negative pressure. Similarly, advise patient not to use carbonated beverages like Pepsi or Coke or any of these carbonated beverages or sodas. These can also act because they are acidic in nature, so they can act on the clot and break down the clot. So these are reasons why we should ask the patient not to smoke, not to spit, not to use a straw, or not to drink carbonated beverages. Similarly, rinsing the mouth. Many times patients feel the blood taste in the mouth annoying. So how do they get rid of it? They try to rinse their mouth. So rinsing is possible provided the patient uses clean cold water, and it should be very gentle. Okay, the rinsing should be very gentle. If they do a vigorous rinsing, the mechanical force of rinsing can again dislodge the blood clot from the socket, and the patient might end up with a dry socket or delayed wound healing. And after the first 24 hours, so this is the first two instructions that we tell here is in the first 24 hours. But after the first 24 hours, the patient can start rinsing. The reason is the clot would have already started organizing around the peripheries of the socket, so it may not be dislodged so easily. So they can rinse their mouth, but again, the rinsing should be gentle. And in after 24 hours, rather than cold application, warm application helps the patient. So we tell the patient to use warm mouth rinses, which they will do after every meal. So the idea behind using a warm saline mouth rinse is the warmth will increase blood flow into that area. So this will help in reducing the inflammation. Using salt water or saline has certain antibacterial properties, so it can prevent infection. And rinsing gently will clean the area of any food debris. So the patient, when they drink or eat something soft or drink something like a liquid, the food debris gets stuck within the extraction socket area. So when you do a gentle rinse, this cleans up the area. So this kind of rinsing is advised to the patient to be done after 24 hours and can be continued up to 1 to 2 weeks after extraction. Especially if you have done a suturing, you have to tell the patient to do the warm saline mouth rinses after every meal until the sutures are dissolved or they are removed by the dentist. So this is important to know. So other postoperative instruction is if you have an upper teeth removed, especially an upper molar, tell the patient not to blow the nose. The reason is that the tooth root may be very close to the maxillary antrum. So sometimes the only separation between the maxillary antrum and the extraction socket is a thin lining. So if they blow the nose, any negative pressure in the nose can cause breakdown of this thin lining. So it can lead to an oroantral communication. So this is very important. And even if they are sneezing, it is important that they use a handkerchief or a tissue to prevent the increased pressure while sneezing. Uh, I told you a little while ago that in the first 24 hours, we ask patient to use cold, and then after 24 hours, we ask the patient to use warm. The idea behind using cold is to reduce the bleeding from that area. When there is more blood flow into that area, it will cause more bleeding. So when we apply ice or use cold water, this causes vasoconstriction, and vasoconstriction will reduce the bleeding from the extraction site or surgical site. So this can be done by cold drinks which the patient consumes, or it can also be affected by applying a cold pack, an ice pack. And usually an ice pack is applied for 20 minutes on and 20 minutes off. Like the patient keeps it applying over the skin near the extracted area for 20 minutes. Then they leave it unapplied for 20 minutes. Then they do it again. So they can do it like this for 4 to 6 hours, but it's done only within the first 24 hours. Applying ice after 24 hours, although does not do any harm, it does not have any benefit as well. Similarly, whenever you have a surgical extraction where you do removal of bone, make a flap, sectioning of tooth, application of ice can also help in reducing the swelling, because when there is reduced blood flow, there is reduced inflammatory mediators into the surgical site, and this will also reduce the amount of swelling that can happen to the patient. These are the general instructions, the ones that we discussed before. So there are certain specific instructions with regard to the physical activity which a patient can undertake after extraction. So usually physical activity should be avoided in the first 24 hours. So physical activity is anything that you will exert yourself, like going to the gym, okay, doing a lot of heavy lifting, okay, whether it is at the gym or at your workplace, or driving long distances, walking or running long distances, and also speaking for long durations. Like for example, I am giving a lecture. So probably if I had an extraction today, I am not supposed to give you this lecture, because for me, talking more than 15 to 20 minutes is going to cause mechanical effects within the oral cavity, and this can dislodge the blood clot. So this is very important in terms of physical activity. And we do not follow it here. Sedation is not being done in the outpatient setting here in Saudi Arabia, except for the pediatric clinics where they give nitrous oxide. But in adult, in certain clinics or probably in certain centers, they may give sedation in the outpatient clinic for extractions also. So in such cases, the patient should be advised not to drive or operate heavy machinery for at least 24 hours. So this is regarding the physical activity. And also dietary restrictions are very important after extraction. The patient cannot eat whatever they want after the extraction, because solid foods, any food that needs a lot of chewing, will cause mechanical effects that will break down the clot or dislodge the clot. So whenever the clot is lost, we end up with dry socket, delayed wound healing, and wound infection. So the primary idea, if you look at it behind all of these post-operative instructions, is to make sure that a good clot, a healthy clot is formed within the socket. So in the dietary restrictions, what we tell the patient is the first day, that is 24 hours after extraction, the patient should take only soft or liquid diet, and it should be cold. Okay, so they can take something like jellies, pudding, yogurt, applesauce, mashed potatoes, ice creams, milkshakes, all of that is fine. So when they drink something cold, let it not be a carbonated beverage like soda. Okay, because I told you the reason why. Anything other than that, fruit juices, milk, laban, anything is fine. And soups can be taken as long as they are cold. Okay, patients should take cold or room temperature soups. And when do they resume their normal diet? Usually the patient can start taking warm foods by the second day. That is, after 24 hours, the patient can take warm foods. But again, it should be a little bit soft, and gradually they go to their normal eating habits by 2 to 3 days. So if I do the extraction today, until today, tomorrow morning, they should not take anything hot. They should take only soft and cold or liquid diet. From tomorrow, they can take soft, warm diet. Probably from day after tomorrow, they can start eating their normal food. And after 24 hours, when they start eating the warm food, that is the time they should start using the warm saline mouth rinses. So after they eat anything, they have to do the warm saline mouth rinse. And if it's a normal extraction, it should be done at least for 1 week. And if it's a surgical extraction where a suturing has been done, it has to be the warm saline mouth rinse has to continue until the sutures are dissolved or the suture is removed by the dentist. So what about medications? Usually the surgeon or the dentist would prescribe antibiotics or analgesics as and when required. In most cases, analgesics are routinely prescribed after any extraction because pain would definitely happen. But antibiotics are given depending upon the patient's health condition or depending upon the type of extraction done. So when there is no susceptibility for infection, there is no need for antibiotics. But analgesics need to be given at least for the first 24 hours so that the patient can tolerate the post-extraction pain. And mouth rinses, usually warm saline mouth rinse is more than enough. But in patients where you expect infection to happen, patient is an uncontrolled diabetic, patient has systemic issues, patient has immunocompromised state, then an antibacterial mouthwash like chlorhexidine would help the patient. And in case of infection, you can prescribe an antibacterial mouthwash. So this is what we do. And last but not the least is follow-up care. So you have to tell the patient what should they do uh, when the procedure is finished. Like for example, you do an extraction, should they come up to you again or not? So usually for simple extractions, there is no follow-up required until and unless patient has a complication. If the patient has no complications, that's it, they can lead their normal life. But if you do a surgical extraction or if you do an extraction where a suturing has been done, it is better to follow up the patient at least 1 to 2 weeks after the procedure. For two reasons. One is to check on how the healing is. And the second reason, if the suture is still persistent, you may have to remove the suture. The idea why I am insisting that sutures intraoral have to be removed is the suture can act like a foreign body which will attract all the food items. So whatever the patient eats, it will just stick onto the suture material. So within 1 to 2 weeks, it is better to remove the suture to avoid any complications. And you can also advise the patient to write down whatever queries they have and when they come back for the follow-up visit. So when should the patient contact the dentist? Okay, so what is an emergency situation? Number one, if the bleeding does not stop after 4 hours. And here again, you have to tell the patient bleeding means fresh blood, okay, whole blood coming from the socket and not blood mixed with saliva. Number one. Number two, if the patient has sudden increase in swelling or bruising, bruising is like reddish discoloration under the skin. If the patient has severe pain, which is not relieved by analgesics, and if the patient develops any side effects to the medication, it could be to the local anesthetic, it could be to the analgesic or the antibiotic. So it could be allergy, nausea, rash, hypersensitivity, anything, the patient has to come to the emergency. And if the patient develops a fever, temperature more than 100.5 degrees within the first 24 to 48 hours, then that is also a cause for reaching out to the emergency. So how do you do that? So in all cases, the post-operative instructions have to be told to the patient verbally, and they should also be given as a printed note. Okay. And in the printed note, you should have an emergency contact number, which is usually the clinic's reception or the emergency. Like for example, in most cases, our clinics do not function 24 hours. They work from probably 8 in the morning till 4 in the evening. So what happens if the patient develops a problem after 6 p.m. in the evening? So you have to tell them the nearest emergency where they have to go to. So the routine procedure we follow here is if it is during the working hours, the patient comes to the dental emergency, either in the male campus or the female campus. And if it is beyond the working hours, they go to the emergency at King Khalid or King Abdulaziz University Hospital. So this is the protocol that we follow here for King Saud University Medical City. So this is about the post-operative instructions. So if you have any doubts, you can just ask me now, or we can go ahead with the next one. Okay. So let us proceed with the next lecture. So the next one is a little bit in detail about what are the medication we prescribe patients after an extraction. So this is what we call it as post-operative therapeutics. Although the word post-operative means after any surgical procedure, our lecture today is going to focus about post-extraction antibiotics and analgesics. Okay, so these are the two main medications that we prescribe patients after a dental extraction. So what is an antibiotic? An antibiotic is a chemical substance which is derived from microorganisms to target other microorganisms. This is simply put definition. But these days, we are actually getting chemically synthesized antibiotics as well. So it is better to use the term antimicrobials, okay, or rather than an antibiotic. So an antimicrobial is a drug that is used to kill any microbe. So this is how it works. So how do we classify antibiotics? A brief note about the classification is mainly based on their mechanism of action. Okay, which part of the bacteria they are targeting and how they destroy the bacteria. So this is what defines how the antibiotic is classified as. So if we look at it, we have antibiotics which target the cell wall synthesis. So they inhibit the cell wall synthesis, that way they kill the bacteria. So this includes examples like penicillin, cephalosporin, vancomycin, and other things. Cell membrane, okay, if you look at bacteria, we have gram positive and gram negative bacteria. The gram positive bacteria usually have a thick cell wall, whereas the gram negative bacteria, they have only a very thin cell wall, which we call it as a cell membrane. So the cell membrane is targeted specifically in gram negative bacteria by a group of antibiotics called as the polymyxins. Then there are antibiotics which target the nucleic acid, that is the DNA and the RNA. So similar to human cell, the bacterial cell also has DNA and RNA. So the synthesis of DNA and RNA is responsible for multiplication of the bacteria. So anything that inhibits this DNA or RNA synthesis is called as nucleic acid synthesis inhibition. So this includes antibiotics like sulfonamides, quinolones, rifampin, and all of those. And similar to all animal cells, the bacterial cell also needs to synthesize proteins in the form of enzymes, in the form of cell wall components, in the form of cell membrane components, or the organelles within the cell. Okay, so this protein synthesis can also be inhibited by certain antibiotics. This includes antibiotics like tetracyclines, aminoglycosides, macrolides, clindamycin, and so on and so forth. So basically, this is the primary classification of antibiotics. Based on their clinical use, they are classified in two types. One is based on the mode of action. Mode of action is like how do they stop an infection? So in that case, we have two types. One is bacteriostatic. That means they do not kill the bacteria, but rather they stop bacterial multiplication. Okay. And a bit more advanced antibiotics are called as bactericidal. So cidal, the word cidal means killing. Okay. So here the bacteria are killing, so the antibiotics are killing the bacteria. So bacteriostatic is only stopping multiplication. Bactericidal will kill the bacteria. And also based on their spectrum of action. Okay. Spectrum meaning like which groups of bacteria these antibiotics can target. So we have a broad spectrum antibiotic which will act against several groups of bacteria. That is, they act on gram positive, gram negative, aerobes, anaerobes, and everything. Whereas a narrow spectrum antibiotic targets only a particular group of bacteria, only gram positive aerobes or gram positive anaerobes or anaerobes or aerobes. So something like that. So this is what we call it as the spectrum of action. So again, so this is how we can classify them. And also in the spectrum of action, we also have antibiotics which act only on fungi, viruses, and protozoa. So we call them as antifungals, antivirals, and antiprotozoals. What is the principle of antibiotic therapy? So before we know when to give antibiotics, we should know how to give and why to give. So that is what forms the principles of antibiotic therapy. So there are three important things to be understood. Number one, which bacteria is causing the infection? Okay. So the bacterial flora causing most odontogenic infections. So you need to identify the bacteria. Number two, what is the host defense? So in the previous section of our lecture, I was telling you that we do not give antibiotics always. We give antibiotics only when there is susceptibility for infection. Got it? So if we have a healthy patient and we have an old age patient who has multiple medical problems. So the choice of giving antibiotic is for the patient who is old aged and has multiple medical problems because they do not have a good immunity. Whereas for a healthy patient, the immunity is good, so there is no need for antibiotics for a simple surgical procedure. So only when you do an advanced or an extensive surgical procedure, we need to give antibiotics for this healthy adult. Got it? So the basic mechanism of host defense. So this is what we call it as host defense. So depending upon the host defense, we decide whether to give an antibiotic for a particular clinical scenario or not. The third option, the choice of available antibiotics. What antibiotics that we have, which we can prescribe. So how do we identify the bacteria? Number one is most of the odontogenic infections, most infections in the oral cavity are caused by the normal microbial flora. If you look at our human body, the human body, each individual's body carries antibiotic or bacteria which are persistent throughout our lives. And if for at a given moment, as a human's body has bacteria which is more than even the world's population. Okay, so I'm just giving you a comparison note for you. So that means to say that we all have bacteria in our skin, in our respiratory tract, in our oral mucosa, in our gastrointestinal tract, in our genitourinary tract. All of these places are full with bacteria. These are called as normal microbial flora. And in most cases, these are the ones that contribute to infections when there is an opportunity. So if you take the case of odontogenic infections, which is infections in the dental and the oral cavity, they are usually caused by the normal microbial flora. And this normal microbial flora in the oral cavity includes both aerobes and anaerobes, and they also have both gram-positive and gram-negative organisms. So if you look at the normal flora, okay, in a healthy patient, they are predominantly gram-positive aerobes. But when an infection happens, there is a shift in the flora and they become more of gram-positive anaerobes. So how we decide on the host defense mechanism? We just have to see whether the patient has any depression or immunosuppression of the immunity or the host defense mechanism. Diseases such as malnutrition, immunosuppression, systemic diseases like diabetes, long-term steroid intake, liver failure, kidney failure, all of this can also bring down the host defense mechanism. Sometimes even drugs, patients who are treated for cancer, who undergo chemotherapy, patients who take a long-term steroid medication, they also have impaired host defense mechanism. And choosing the antibiotic, again, that is dependent upon three things. One is identifying the organism, then determining antibiotic sensitivity, and then finally the available antibiotics. So how do we identify the causative organism? So usually for simple infections, we do not go and do a specific procedure to identify the organism. Usually after extraction, if I have to give an antibiotic for a patient, it is usually based on the available knowledge. Okay, I know that after extraction, if an infection happens, it is usually due to the normal oral flora, and the normal oral flora is usually gram-positive aerobes and anaerobes. So I can specifically, I need not go in specifically to identify the organism, but rather I can give a broad spectrum antibiotic which will cover both the uh, gram-positive aerobes and anaerobes. But in case there is a severe infection, a patient comes with a huge swelling and abscess, a pus discharge is there. So in such cases, giving a generic broad spectrum antibiotic may not help the patient. So we need to identify which bacteria is responsible for this abscess. So how do we do it? We do by what is called as antibiotic sensitivity testing. So we take a sample from the infected area and we send it to the laboratory. What will the laboratory do? The laboratory will grow the bacteria in this sample. So this is what we call it as taking a swab. Okay. So you all would have heard about taking a swab during the COVID testing, right? So they used to take a nasal swab to identify if the COVID virus is there. Same way, when we have an infection, a long-standing infection or a severe infection like an abscess, we just take a swab from the pus or these exudate from that area. And this is sent to the lab, and the lab will grow the microorganisms present in it, more specifically the bacteria present in it. And not only would they do grow the bacteria, they will also do testing for which antibiotic is more effective against this bacteria. So this is what we call it as antibiotic sensitivity testing. So once the antibiotic sensitivity testing results are out, they will say, okay, so this bacteria is Staphylococcus aureus, and the antibiotic to which it is most susceptible is amoxicillin, or they might say it is cephalexin, or it is clindamycin. So they give me a specific report. So once I have the specific report, I just give that particular antibiotic to the patient, and it will destroy all the bacteria that is causing the infection. So this is how we identify the causative organism and target the organism. This is done when there is a severe infection or when the patient is highly immunocompromised. But for routine cases where we do an extraction and need to give an antibiotic to prevent infection, or when there is mild infection, we give an antibiotic based on our knowledge, which is to cover the normal bacteria which might cause the infection. So usually in this case, it is the oral cavity bacteria, which are predominantly gram-positive aerobes and anaerobes. So we have a lot of antibiotics available in the armamentarium. So which one do we give? So the choice is dictated by if the patient has any history of allergy. So the patient should not be allergic to a particular bacteria antibiotic. So that one you will give. Always try to give a narrow spectrum antibiotic. Give an antibiotic which has least toxicity or adverse reactions, and also try to be judicious in prescribing an antibiotic which is effective and at the same time not expensive. Okay. And within bactericidal and bacteriostatic antibiotics, it is always better to give a bactericidal antibiotic because it kills the bacteria and not just stops multiplication. So if it stops multiplication, whenever the host immunity goes down, or when the antibiotics discontinued, the bacteria can start remultiplication again, right? So it's always better to kill the bacteria. So bactericidal antibiotics are the preferred choice than bacteriostatic. And similarly, the systemic status of the patient. So antibiotics not only act on the bacteria, they can also sometimes cause adverse effects to the liver, kidney, and the metabolic system. So you'll have to be very careful to know the systemic status of the patient before you give such an antibiotic. So some commonly used antibiotics, I'll just discuss a few of them. It will be a quick rush through. You can just read from the slides for the sake of the exam. So penicillin is one of the most commonly used antibiotics. It was originally obtained from the fungus Penicillium notatum, and this was the first discovered antibiotic by Alexander Fleming in the Second World War. It's 1940s. We are talking about around 8 decades from before now. So antibiotics are that old. And they form a group of antibiotics called as beta-lactam antibiotics, and they are very effective against gram-positive and gram-negative cocci and bacilli. So these were the primary groups of bacteria which they were targeted to use. Over the period of time, natural penicillin evolved into acid-resistant penicillin. Then we had penicillinase. Okay, so bacteria started developing resistance to penicillin. So what the bacteria did, it started producing penicillinase, an enzyme, and this enzyme used to kill the antibiotic. Okay, so bacteria like found a weapon against the antibiotic. So this is what we call it as penicillinase. So we had to evolve by producing penicillinase resistant penicillins. And then there are synthetic penicillins, which are very commonly used these days, which includes amoxicillin and ampicillin. And we also have extended spectrum penicillins, not only gram positive, they also work on gram negative, both aerobes and anaerobes. And we reserve this for extensive infections where you're not able to pinpoint on a particular organism. So that is where we use the extended spectrum penicillins. So commonly prescribed for the oral infections is amoxicillin. Okay, so orally you can give amoxicillin 250 to 500 milligrams, and it's given in a frequency of 3 to 4 times a day for up to 5 to 7 days. The pediatric dosage, in all cases, if you take the case of children, we don't give a fixed dose. We rather calculate the dose based on the weight of the child. So, for example, the child is around 40 kilos weighing, and depending upon how severe the infection is, we may choose to give 30, 40, or 50 milligrams. So, if it's a severe infection for a 40-kilo child, so you have to give 50 milligrams per body weight, kilogram of body weight. So, 40 times 50 is around 2000 milligrams. So, you have to give up to 500 milligrams in 4 divided doses. So, this is how we calculate the dosage. And similarly, when you want to give the medication as an injection and not as an oral administration, you have to also again calculate the dose based on the weight. An advanced form of amoxicillin is called as augmentin. Basically, augmentin has amoxicillin and clavulanic acid. So I was talking to you about penicillinase, right? So similar to penicillinase, there is an enzyme produced by certain bacteria which is called as beta-lactamase. So all of these bacteria, antibiotics, penicillin, cephalosporin, they have a beta-lactam ring. Okay, it's a chemical structure. So this beta-lactamase enzyme produced by the bacteria breaks down the beta-lactam ring of the antibiotics, rendering the antibiotic ineffective. So in order to inhibit beta-lactamase, they add clavulanic acid, which is a beta-lactamase inhibitor. So when you combine amoxicillin with clavulanic acid, the effectiveness of the antibiotic is enhanced. So you have a much better bactericidal action than when using amoxicillin alone. Penicillin, being the first antibiotic, has been widely studied and also has a greater degree of adverse effects. It includes intolerance, hypersensitivity. In fact, they say that nearly 0.1% of all people who use penicillin are allergic to penicillin. And the problem with penicillin allergy is like uh, one out of every patient who's out of 100 patients who are allergic to penicillin could have a life-threatening reaction, like an anaphylaxis or a life-threatening allergic reaction. So you have to be very careful when you prescribe antibiotics. Tetracyclines are also another old group of antibiotics. They are a broad spectrum antibiotic, and the problem with tetracycline, why they have not been used more often than penicillin, is because they are bacteriostatic and not bactericidal. As they are broad spectrum, they act against both gram-positive and gram-negative organisms. We still use them for certain periodontal infections. Doxycycline is still used for periodontal infections. And multiple disadvantages include diarrhea, nausea, vomiting, and one more problem with them is like they can cause teeth discoloration if administered to a pregnant woman. So if you give it to a pregnant woman, tetracycline, the child who is born to this pregnant woman might have teeth discoloration. Similarly, when there is teeth formation, when you're giving it to a child, it can cause discoloration of the permanent teeth. So this is a teratogenic effect which can occur with tetracycline. Cephalosporins are a recent generation of antibiotics. They are in use for the last 3 to 4 decades. And they actually were evolved from penicillin because they have the similar structure as penicillin. They have the beta-lactam chemical ring. So they are also coming under the beta-lactam antibiotics. So because of that, there are two things. One is an advantage because all the bacteria that are susceptible to penicillin but developed a resistance became susceptible to cephalosporin. So now we have a new weapon in our armament, in our armory. But the problem is bacteria started developing resistance easily against cephalosporins because of the beta-lactam. So anything that had a resistance to penicillin, they also started developing a resistance to cephalosporin. And we also had another problem. Many patients who are allergic to penicillin, in those who are, it was due to the beta-lactam chemical structure, they were allergic to cephalosporin also. So there is cross-reactivity or cross-hypersensitivity. So again, these are all small problems, but again, we have to remember that whenever we give an antibiotic, the most important thing is like we should avoid all adverse effects or complications. So cephalosporin as an antibiotic clinically is very highly effective against both gram-positive and gram-negative bacteria. And several advancements in cephalosporin development have happened. So initially we started the first generation, now we have till the fifth generation. So the only difference is the first generation was more towards gram-positive bacteria, whereas the recent ones, the fourth or fifth generation, they are more active against gram-negative microorganisms. Cephalexin is a commonly used cephalosporin. Okay, so this is a first generation cephalosporin. It has a similar action that of penicillin. Similar action in the sense, like similar spectrum of action. That is, it acted against the same bacteria which was being killed by amoxicillin and penicillin. So if a patient who is allergic to amoxicillin or penicillin, cephalexin could be given, but again with caution because cross-reactivity is there for a very small fraction of patients. The dosage of cephalexin is around 250 to 1 gram, given in a 6 to 8 hourly dosage. In children, it is 25 milligram to 100 milligram per kilogram per day. Adverse effects included pain after injection, diarrhea, nephrotoxicity, and as I told you, cross sensitivity in patients who are allergic to penicillin. Imidazoles are another group of antibiotic. Okay, so these are more specifically acting against the anaerobic organisms. So again, there is a bit of a controversy here because some clinicians, they say that the anaerobic organisms which cause chronic infections, oral cavity infections, and periodontal infections, the imidazoles are effective. But there are certain physicians who say that imidazoles are effective only in the gastrointestinal tract and not in the oral cavity. But still, we have been using them and it is giving proven clinical benefit, especially in cases where there is a chronic infection like an abscess or a periodontal infection or a necrotizing gingivitis or periodontitis. And usually it is given in the dosage of 400 milligrams every 8 hours. And IV infusion can also be given and treatment usually continues for around 7 days. Main indication for antibiotic usage include hard tissue trauma and soft tissue trauma. Any major surgery, we do it. Surgical extractions, and in extractions which we do for patients who have a immune problem when they have a reduced host defense mechanism. So then you have to give the antibiotic. So next one is analgesics. Analgesics are usually administered for relief of pain. Okay, so originally analgesics were called as opioid analgesics. Okay, but now we predominantly use what we call it as the non-steroidal anti-inflammatory drugs. So the biggest problem with opioid analgesics was their abuse potential. Patients used to get addicted to opioid like morphine, pethidine, because they used to have a mood elevation effect. So they used to get um, a problem. They have an abuse kind of effect. They used to get addicted to the use of opioids. So in order to overcome this problem, we developed what is called as the non-steroidal anti-inflammatory drugs, and these are the commonest analgesics that are being used today. There are several classifications of non-steroidal anti-inflammatory drugs. Okay, so basically all of them act on the enzyme called as the cyclooxygenase. So the cyclooxygenase is an enzyme which breaks down the plasma membrane after an injury. And this enzyme is responsible for producing the mediators of inflammation such as prostaglandin, thromboxane, and prostacyclin. Okay. So we have two of these cyclooxygenase. One is called as the cyclooxygenase 1 and the other one is called as cyclooxygenase 2. So the cyclooxygenase 1 has a protective function. Basically, it protects the mucous membranes all over the body, mucous membrane in the respiratory tract, mucous membrane in the intestine, and all over the areas. And whereas the COX-2 is the one responsible for inflammation. But the problem with most of the older non-steroidal anti-inflammatory drugs, they used to inhibit both the COX-1 and COX-2. So resulting in reduction in inflammation because of COX-2 inhibition. But as it inhibited COX-1, it started irritating the respiratory mucosa. It started irritating the gastric mucosa. So patients usually started having asthma-like reactions. Patients started having acidity, gastritis kind of reactions. So because of that, the later generations have been focused on using more COX-2 inhibitors, COX-2 specific inhibitors. But still, we are using the non-selective COX inhibitors in patients who are able to tolerate it. Because if you look at it, ibuprofen and diclofenac are some of the commonly used analgesics. They are non-selective. They still inhibit the COX-1, but patients are able to develop a tolerance for the side effects that come in the respiratory tract and the gastrointestinal tract for these patients. So the first discovered non-steroidal anti-inflammatory drug is aspirin. Developed analgesic is aspirin. Okay, so it is basically an acetyl salicylic acid. So what happened is like they found out that aspirin was very problematic in terms of irritating the gastric mucosa, and another problem is aspirin also affected platelet function. So after an injury, we need to have platelets adhering to one another to form a clot. So, but aspirin did not allow the platelets to stick to each other. So they found that aspirin has severe bleeding tendencies in these group of patients. So nowadays, aspirin, more than being used as an analgesic, it is more used as an antiplatelet drug. So for patients who have the susceptibility to form easy clots, like patients with heart disease or patients with brain disease, they form clots in the blood easily. So to avoid that, they give a small dose of aspirin. So aspirin as a painkiller is not being used anymore. It is more used as a antiplatelet drug. So the next one, which is more commonly used, is ibuprofen. And even today, ibuprofen is a very good analgesic, especially for dental pain. Uh, and it does have respiratory and gastric side effects, but many of the patients are able to tolerate it at smaller doses. So usually a dose of around 400 milligrams, which is taken like 1 to 2 times a day, does not cause severe gastric or respiratory side effects. So when the patients are able to tolerate it, they can use it. One important difference between antibiotics and analgesics that you have to remember is if you give an antibiotic, if you prescribe it for 5 days and you have the patient to take it 3 times every day, the patient should complete the entire course of antibiotic therapy. So if you are prescribed it for 5 days, 3 times every day, the patient should take all those doses. The reason why is if the patient stops it in between due to improvement in symptoms, the bacteria can start developing resistance. So antibiotics should always be administered in a course and the patient has to be instructed to complete the entire course of antibiotic therapy. On the contrary, if you take analgesics, it is never in a course. Always analgesics are prescribed when needed. So you tell the patient, okay, take ibuprofen 3 times every day for 5 days, but you don't need to take it when you don't have pain. So the good thing about analgesics is patients can discontinue it if they have improvement in symptoms. Similarly, the pain threshold may vary from person X to person Y. Person X may have a very good pain threshold. They will tolerate pain without analgesics. But whereas person Y cannot even tolerate the mildest of pain without analgesics. So in such cases, patient Y may need more analgesics, but patient X doesn't need analgesics. So analgesics are always used based on convenience. So when the patient has pain, they use it. When they don't have pain, they don't use it. So that way, we are able to reduce the amount of side effects that are associated with the analgesics. Diclofenac is also a very strong non-steroidal anti-inflammatory drug. In fact, it is prescribed when we have surgical extractions because of the drug's ability to penetrate into bone. Okay, so it is bone and tissue fluid penetration with diclofenac is high, so it has both anti-inflammatory and analgesic action. Acetaminophen is actually a separate class of drug. Although we classify it under non-steroidal anti-inflammatory drugs, it does not fall under non-steroidal anti-inflammatory drug. Aspirin, ibuprofen, diclofenac, these come under NSAIDs, but acetaminophen is a separate group. The reason is that all of the ones before, aspirin or ibuprofen or diclofenac, they have two actions. They have a dual action. Number one, they have anti-inflammatory action, and they also have an analgesic action. So they reduce inflammation, they reduce pain. Whereas acetaminophen or paracetamol, or commonly known as Panadol or Fevadol here in the market, it has only analgesic action. It has zero or very minimal anti-inflammatory action. I would rather say zero anti-inflammatory action. Okay, so it is a very good painkiller, but it's a very, very, very poor anti-inflammatory. So when do you prescribe paracetamol? When you expect zero or less inflammation, you can give paracetamol only for pain relief. But in cases where you expect more inflammation, like for example, I have a simple extraction where there is less chance for inflammation, paracetamol is more than enough. But when I do a surgical extraction, when there is chance of inflammation and pain, I should either prescribe ibuprofen or diclofenac. Okay. Okay. Why do we make the choice? Why not give ibuprofen and diclofenac if the patient tolerates it? The safety profile. Paracetamol is a very safe drug. You give it for even newborn children. Okay. Only reason, only thing that you have to be careful when you give it in newborn children or infants below 6 months of age is you should not give a higher dosage because it can hit the liver. But anybody who's more than a year old, they can take paracetamol up to the safe dose. There is no problem. It is very safe. Patients are tolerating it very well. There is very little risk of hypersensitivity or allergy with paracetamol, and there is no risk of respiratory adverse effects or gastrointestinal adverse effects. So whenever possible, when you expect less inflammation, it is better to prescribe only paracetamol for patients after extraction. But when you anticipate inflammation, it is better to give them ibuprofen or diclofenac, which is a non-steroidal anti-inflammatory drug. Opioid analgesics, of course, these were the first group of analgesics, and I was telling you the biggest problem with them was the abuse potential. Patients tend to get addicted because of the mood elevating effect. So we still use them, but only for extensive surgeries. When you do a general anesthetic surgery for a big procedure, then you give opioids for pain relief. And it is a restricted prescription. You cannot write a prescription and give your patient in the clinic. It has to be administered only in the hospital. It can never be outside the hospital. So for this reason, opioids are restricted only for extensive surgeries and only within hospitals. All the others, you can do it as a prescription. So what is the guidelines for analgesic use? Main thing is eliminate the source of pain whenever possible. Individualize the regimen based on the pain severity, the ability of the patient to withstand pain and things like that. Always try using a non-opioid before using an opioid because of the abuse potential associated with opioids. And optimize the dose and frequency tailor-made to the patient. And for NSAIDs, you can always consider giving a pre-operative dose. Okay, so you give ibuprofen before even the extraction. So this way, the pain is much lesser, and post-operatively, the patient takes less dose of ibuprofen. So this is one thing. And also prescribing it not at a high dose at one point, rather giving it around the clock. Okay, so that way the patient has a pain-free episode for a longer duration of time. And always tell the patient to discontinue the analgesic when the symptoms improve. When the pain reduces, when the inflammation reduces, stop the analgesic. Okay. Unlike antibiotics, which has to be taken for the full course. And this way, you can avoid chronic use of analgesics and also reduce the adverse effects associated with the analgesics. Before we conclude, this is very important, okay, because this is about therapeutics. So you need to know how to write a prescription. See, we talked about antibiotics and analgesics, but if I don't know as a clinician how to write a prescription, then the whole purpose is defeated. So this is the way we write a prescription. There are certain important information that we need to know or we need to enter in a prescription. Number one, the patient details. Okay, so the details include the name of the patient, the age, gender, and the medical record number. So four important details of the patient should be there on the prescription. Number two, the diagnosis for which the prescription is made. So the diagnosis could be infection, post-op, or after extraction, or for prophylactic, or whatever it is. Number three, the drug, the name of the drug, whether it is an antibiotic or analgesic, the name of the drug should be mentioned. Then three important things come, okay? For every drug, you should mention the dosage. The dosage is the strength of the medication. It's usually in milligrams, like 250 milligrams, 500 milligrams, 1 gram. So this is the dosage. The second thing is the frequency. Frequency is like how many times the patient has to take this medication in a given day, whether they should take it 3 times, whether they should take it once, whether they should take it twice or 4 times. So this is the frequency. And the third thing is the duration. For how long? Like, for example, is it for 1 day? Is it for 3 days? Is it for 5 days? Is it for 7 days? So the name of the drug, okay, along with it, you need to have three important information, which is the dosage, the frequency, and the duration. Additionally, you can add the route of intake. So usually all over the counter prescriptions are orally given. Okay, only the inpatient prescriptions are given as injections. So route of intake has to be given. Sometimes topical application, or if you're prescribing a mouth rinse, you should say that it is only for local use. It's not for swallowing. Okay, so that has to be mentioned. Then any special instructions. So should I give it before food or after food? Okay, so for a painkiller, should it be taken continuously or should I stop after the pain subsides? And last but not the least, it should be the signature and name of the prescriber. The clinician who's prescribing it has to put their name, if possible, an ID number, okay, and their signature. So this is how we make a prescription. So here we have a sample prescription, which we used to use. Of course, now we have digital prescriptions in hospitals. This was a paper-based prescription. So it used to have the name, gender, the age of the patient, and along with it, the medical record number has to be entered, the diagnosis for which the prescription is made. And if you look at the drug, okay, so here we are prescribing an antibiotic, amoxicillin, and an analgesic, ibuprofen. So for amoxicillin, we give the dosage, which is 500 milligrams. The frequency, Q8H here means every 8 hours, and the duration, which is for 7 days. And the special instruction is to be taken by mouth after food. Okay, so the patient should not take it on an empty stomach. They should eat something and then take it after that. For ibuprofen, again, we have mentioned the dosage, which is 400 milligrams, the frequency, which is Q8H, which is again every 8 hours or 3 times a day, and for 7 days, which is the duration. Dosage, frequency, duration. Remember, that's very important. And then the special instruction is per oral, which is by mouth, after food, not take it on an empty stomach. And PRN, the word PRN here means when needed in pain. Okay, so these are certain abbreviations which we follow when we write prescriptions. So PRN here means when needed in pain, so that the patient will take it only when he or she has pain, and when the pain subsides or the symptoms improve, they will discontinue the analgesic. So we did not write it for the antibiotic because the antibiotic has to be taken for the complete dosage. And here we write our name, our signature, and the date. So this is how a prescription is made.